So, hello everybody. I'm here in Florida. I'm going to talk today with my friend Bob Kaplan, who is in California. He works at Stanford, and we are going to first talk about his new book that was published a month ago, More Than Medicine: The Broken Promise of the American Health. And it's a very interesting book. It talks about how much social environment is important to health, and maybe we don't look at this too much and look at effect size of therapies and medicine, and maybe we overestimate those in relation to the social issues. So it's very good. We first are going to talk about this, and then we're going to talk about an article he published in 2015 at PLOS One that talks about scientific integrity, likelihood of no effects of large HLBI clinical trials has increased over time. And he published a comment in our evidence journal, the Journal of Evidence-Based Healthcare. And this interview will be related to this first. So, Bob, thank you very much for talking to us. And I'd like first to ask about your book and the main message of your book.
Well, first of all, thank you. It's good to see you. So the book is the title is, as you mentioned, is More Than Medicine: The Broken Promise of American Health, and it describes my experiences over the course of a very long career, having spent a lot of time working on large NIH-funded clinical trials when I was a professor at the University of California in San Diego and later at UCLA, and then how that moved over into my experiences when I was one of the associate directors at the NIH. And so part of what I get into is what is the return on investment for a lot of what we spend money for, both in the delivery of healthcare and also in biomedical research. So the first few chapters, and this is a very American centric, but I look at well, how is American health doing in relation to the health status in other rich countries? And I think that a lot of people are less aware that the United States, in terms of life expectancy, was about in the middle of rich countries back in 1980. But since 1980, life expectancy in the United States has been declining systematically. So in one study that we sponsored when I was at NIH, that we discovered that the U.S. dropped to last place among wealthy countries. And it had gone from essentially the middle of the distribution to last place over the course of about 30 years. And for some indicators, for example, the probability of reaching your 50th birthday, that the probability of, so the U.S. ended up in last position, but for women, we were almost off the scale. So it's not just that the U.S. is in last place, but in last place by some significant margin. And so a lot of what I get into in the book is, do we have it right? Or are we focusing our attention on the right issues? So anyway, that's how it begins. And if you like, I'll just sort of expand a little bit on what happens in the book. So the first part of the book looks in some detail at our investments in basic science. And I should say that I'm a big fan of basic science. I worked in basic science in the past. But if you look at the total expenditure on basic laboratory research versus clinical research at the NIH, it is somewhat lopsided in favor of basic laboratory science, even though the numbers that are reported are about 50-50. It's a little bit more. So Mike Lauer, who's the director of extramural affairs at NIH, had a blog that was pointing out that about 70% of NIH studies are either mouse studies or they're predicated on mouse studies. And so got into this in some detail and looked at what's really coming out of mouse studies. In particular, do results from mouse studies generalize well to humans? And what we discovered is that mouse studies actually often don't generalize well to rats. And so even within rodents, there isn't generalizability. In certain areas like neurological sciences, there are clinical trials in Alzheimer's disease that are predicated on successful therapeutics in mouse models. And that one of the recent meta-analyses showed that about over 200 RCTs of these same molecules when tested in humans didn't work. So that's one sort of theme.
So
Another theme is,
why do you think that I mean basic science is so much overestimated? Is it because it's more elegant to do something in the lab, or it's because you can make a career easily? Uh, you know, having a lab and getting fund to your lab, and it's like a research for the sake of research sometimes in terms of a
yeah.
scientific importance. What do you think? Why is the people value so much basic science?
Well, it's a great question, and I think part of it is having worked in basic science labs. It's extremely satisfying to understand something mechanistically, even if it's a principle that doesn't generalize well across species. So that piece of it, the understanding of mechanism and so forth, is very exciting. And I just want to make it clear that I'm a supporter of basic science. It's the total portfolio and mixture of what's going on. And I think that the public has this expectation that, we see this in some pharmaceutical advertising in the US where they'll have an ad in a newspaper and they'll have basic scientist in the laboratory, and then next to them there's a picture of a patient. And that, the message is this basic scientist is solving a problem which will be used in the clinic tomorrow to care for that patient.
Yeah.
Which I think is a narrative that's just not not right.
Besides the fact that the biological system is complex and sometimes establish a mechanism does not guarantee clinical effectiveness, do you think that in basic science the problem with multiplicity of analysis are worse than in clinical science?
So in the book, I do get into this exact problem, and that I think it is a very serious problem. And of course, my Stanford colleague John Ioannidis has been focusing on this for some time. So the multiple comparisons problem is very common in basic and in clinical science as well, to be fair. But so what happens is there are multiple outcome variables, there are small trials, and so forth. And we did look at a variety of these the replications and in some basic science, or actually early animal models of therapeutics, and the replication rate is as I know is extremely low.
Yeah.
The other issue that I mentioned, and again I think I'm on shakier ground because I don't understand this clearly, but one of the issues that people neglect is that the human body is a very complicated system, and so if you talk to systems engineers, they have feedback loops and so forth. So the idea that all the systems in the human body act in a linear fashion probably is not right. We evolved over the course of maybe 80,000 generations, several million years. And so for processes like glucose metabolism, there's systems based on other systems, and these systems feed back on one another. So the idea that if you put a molecule or a compound into somebody that lowers their blood sugar, then you fix the problem. Or similarly, perhaps a compound that lowers blood pressure, where in fact you probably are doing more than one thing. And I think that understanding complexities in feedback systems, the engineers say that if you have a system in engineering and you optimize the system based on one component of the system, you'll perturb the entire system. And I worry that may be the problem with a lot of medicines.
So regarding medicines, I think in the past we had magic bullets in terms of advances in the medical field, like antibiotics, vaccination, and maybe more recently the treatment for AIDS. For me,
Yeah.
it was like I remember when I was a resident, the mortality was 100%, and now it's 0%. So I think it's a magic bullet. But many other treatments of modern medicine are not magic bullets at all. The NNT are high, and I think it shows how much we overestimate effect size of treatments. And I believe you mentioned this in your book. So do you want to comment on that?
Yeah, so I do, and of course, a lot of what I've learned from you in the past. But the principles of evidence-based medicine are really important in that there are treatments which, by the way, very successful treatments on a population basis, where at the individual level, the absolute risk reduction can be quite small. And I think it's important to take those into consideration. And I think some of the very most successful medications, like the statin drugs, I think it actually had a profound effect, or at least a major contributor to the decline we've seen in deaths from coronary heart disease. Yet, the one-size-fits-all hypothesis may not be right. There are people in the population whose absolute risk reduction from taking a statin might be very, very small. And again, looking at the recent publications in the Lancet from the cholesterol trialists, for a lot of people, it's maybe 1/10 of 1%
Right.
for all-cause mortality.
Yeah.
Anyway, that is one of the other things I get into in the book is had this interest in surrogate endpoints versus other endpoints that we look at, like disease-specific and all-cause mortality. And so there are a lot of examples where there is a really good effect for the surrogate marker, where there's no effect for all-cause mortality, and in some cases there's, of course, the reverse effect. The Accord trial is one that I always come back to.
But still the FDA still approve medications based on surrogate endpoints, right? So what's your take on this?
Well, so there's been a change in the U.S. in the last couple of years, and that I don't know how well you followed this, but we had something called the 21st Century Cures Act, which was passed in 2016, and that everybody was in favor of it because it gave more money to the NIH. It supported treatment for opioid addiction, so it did a lot of good things. But actually, the real motivation behind it, or at least a lot of people think, was that the pharmaceutical industry wanted to relax the pressure to use non-surrogate endpoints, so that they wanted to go back to using more surrogate endpoints. And so that became law, in that it is easier now to get drugs approved on the basis of surrogate endpoints. And so the FDA was approving about 30 or so new drugs per year in the 5 years running up to the passage of this new law. And then last year, they tripled that, so that it does appear that this new law that allows for other forms of evidence to be used to approve new drugs actually is having an impact. And we could debate about whether that's good or bad. But
So, Bob, talk a little bit about your experience at the NIH and what led to your interest in doing that type of article we are going to talk about.
Well, so by way of background, particularly when I was at the University of California in San Diego, we had a lab that we're looking at quality of life and outcomes in large randomized clinical trials. So over the course of many years, I had worked on a lot of big clinical trials. But by the way, some industry sponsored but many NIH sponsored. And what I came to realize is that the results were frequently not what was expected. And we had examples. This doesn't happen anymore, but in the old days, we would work on an industry-sponsored trial, and if the result wasn't what was expected, then the trial never got published. In fact, it was bad for our academic careers because we had put in all this effort, and the reporting of the trial essentially never happened. So when I went to the NIH, with the help of Mike Lauer, I was able to get data from all the big NIH clinical trials going back 50 years. And with my colleague, Veronica Irvin, we were able to look at these systematically. And we realized that up until about the year 2000, the majority of the trials did show that the treatment worked. And it was about 58% of these trials. But then after the year 2000, the number of positive trials just dropped off a cliff. And so we became curious about, well, how did this happen? I mean, why is it that so many of these trials were non-significant after the year 2000? And of course, we don't know, but our hypothesis is that the FDA Reauthorization Act in 1997, the bill that provides the funding for the FDA, created clinicaltrials.gov. And that, although it phased in later, NHLBI in the year 2000 started enforcing prospective registration of trials, including the prospective identification of the primary and secondary outcome. And we suspect that that's what had this big effect on the number of positive trials.
So it was amazing. I think it decreased from 58% of positive trials before the act to 8 or something, right?
8%, yeah. And one of the things that we looked at is by the way, one of the things that as a reviewer in this meta-analysis, one of the things that made it much easier for us is that the current trials, the ones that are pre-registered and they're reported, with current standards, consort guidelines and so forth, they're very easy to read. And it was actually, we were able to get through those very quickly. The early trials, the ones that were published in the 1970s and early 1980s, actually, it's very hard to figure out what happened. And in particular, you don't know what the primary outcome was. Mm. And so what we suspect happened was that trials were done and there were 30 or 40 outcome measures. Right. And then the investigators looked through them all and found the ones that were statistically significant and reported them. And so when we looked at the new trials, the ones that were published after 2000, similarly, all those trials have multiple outcome variables, but since they prospectively said we're only looking at, CHD mortality or whatever, if you go through all the different outcomes, they actually find a significant effect in just about as many of the cases as the early trials. So we think that this exclusive focus on the primary outcome variable is a big part of it.
Good. So just for the public who will read the article but haven't read yet, you showed a large decrease in the positive rate of trials funded by the NIH from before to after people were supposed to publish the protocol prior to doing the study at clinicaltrials.gov. So I think it was a great advance in terms of scientific integrity, but I want to hear your opinion about the fact that people now, they publish a priori and they say a priori that they can change the outcome, the main outcome, if this and that, based on an interim analysis. So I understand that the pre-publication of the protocol is to avoid people change, and now they write that they will change if they want during the trial. And I want you to comment on the ischemia trial that changed the primary endpoint. What's your take on this?
Yeah, no, I think this is a problem. And so I haven't followed this. I don't think I followed it as closely as we have. But we have looked at that. And we do know that is allowed. And actually what actually gets reported is often not exactly what was prospectively registered in clinicaltrials.gov. I do think that NHLBI has been tighter on this. But what's your take on that? I'm very interested in it.
You mean the ischemia trial?
Yeah.
Well, they changed the outcome based on an interim analysis of the trial that was, the trial already stopped recruiting, and it's now has stopped follow-up. So like less than 1 year before stopping the follow-up. So at the very end of the trial, they did this analysis and recognized the incidence of the event was low. And then they changed the primary endpoint, which was only death, cardiovascular death, and MI, to cardiovascular death, MI, admission for angina, admission for heart failure, and sudden death, something like this. So, so they changed, and people starting to complain at Twitter or something, and there was an article that was published at Circulation Outcomes criticizing this. and they answered that it was in the protocol written that they could change, but it doesn't fix the problem that it was kind of I didn't find I won't find a positive result not here with the predefined primary endpoint, and now I'm going to try another one. So
Yeah.
it's multiplicity.
Yeah.
And the second problem is that this composite endpoint is like a self-fulfilling prophecy because it gets it's an open trial.
Yeah.
So admission for angina or for vascularization, whatever, it's influenced by the fact that I, as a physician, know my patient had not been revascularized before. So it's
Yes.
kind of self-fulfilling prophecy. It's a type of endpoint very susceptible to this bias
Yes.
in terms of this. And the third take I have is that if the incidence of the event was so low that would
Uh-huh.
diminish statistical power, it means that it's not a problem. Events in stable coronary disease, so you don't need to. If the result of the two groups have low incidence of events, it's okay to treat a patient without intervention first initially,
Yeah.
because if it was very high, the total number of events would be high. So I think there is an elephant in the room that people don't see in this primary analysis. I think it's people trying to avoid a very good negative trial.
Right. Well,
They prefer a bad positive trial instead of a good negative trial. That's my take.
yeah, and so null trials are very informative. And one of the things that we realized, we were looking at NHLBI trials, which I think most of those trials, people go into them with true equipoise. And so I think that it is likely, that they're informative and that they should inform clinical practice. One of the things I've become very interested in is that trial protocols when they're made public early, I think it is important for people to look at them. And a lot of times, there is a public comment period, at least, and for things like the U.S. Preventive Services Task Force, when they review things for guidelines, they actually have public comment periods that are quite long, and they look at the comments. I'll just give you one example. There was do you know the Orbita trial?
Yeah.
So, interesting, PCI trial, and that I went to a grand rounds at Stanford where they had a debate. One person was supporting the Orbita results, the other person who was an interventional cardiologist went after them, and that the interventional cardiologist said, well, this was a stupid trial. And he said, I can't understand why anybody would do this trial. And he went through all the reasons why it didn't make sense. And the point is that, in fact, that people did have the opportunity to comment on it before it was done. And I think we need to pay more attention to that looking at the design of the trial, what's registered before it ever starts, I think is quite important.
So you mentioned the Orbiter trial. Just for the listeners, the Orbiter trial is a trial that tested the hypothesis that PCI improves angina, and it was a blinded study. It was elegant because it was blinded, and it wasn't able to show a statistical significant decrease in exercise time, which is an objective marker of angina. I think for that effect size, it's a very good negative trial. It doesn't eliminate any effect size, but it puts our mind in a more conservative way in terms of overuse of PCI. It doesn't prove it doesn't work. It's and I've been talking about this. A trial is not supposed to prove something do not work. It's supposed to prove something work, and it failed to prove it works. So maybe another bigger trial will show a smaller effect. That's okay. But in failing to show it's such a good thing for angina, we should put our estimation of the value of this treatment lower, a little bit lower than we used to be.
Right. I absolutely agree with that. And it was a small trial. It wasn't nearly as big as Courage.
Yes, it was small, but the endpoint was time, exercise time.
Right.
For that endpoint, it was okay for the effect size they plan to detect. So for that, I don't think it was underpowered. But for a smaller effect size on angina, there is no trial with power for any effect size, of course. That's why I say it's impossible to prove something does not exist. The burden of proof is in the existence of the phenomenon, scientifically speaking. And people don't understand this. They start believing and they want the trial to be perfect
Uh-huh.
to stop the belief.
Uh-huh.
It's
Right.
it's an inversion of the logic of science, and I
Yeah.
think so. Very good. I'm very happy to. I'm eager to read your book, More Than Medicine, and I'm gonna buy right away after we finish this. And I'm very happy with your your piece that you comment about your landmark article of 2015. You comment in our journal about that, the meaning of that, and I think it's very impressive. I've been citing that article of yours very much, that the decrease was so much in the positive rate of trials. I wonder, because you studied NIH trials, that conflict of interest is much lower than industry trials.
I think that's
I
right.
wonder
Yeah.
that the problem of multiplicity would be much worse in industry trials, in industry funded trials, don't you think?
It's an interesting question. So industry trials need to register in clinicaltrials.gov, and we haven't looked at industry-sponsored trials. I do think, though, that NHLBI, I think, does start their trials with true equipoise, where on the industry side, I think that there is a tendency to want to design the trial that has a higher probability of showing the treatment works. And there may be subtle choices that are made in the design and execution process where they're not really going into that trial with complete equipoise.
Yeah. Uh, I think that the main trial, even from industry, when now that they have to, publish the primary endpoint, it's an advance. So let's say the main trial published in the New England Journal of Medicine was a negative trial. But what I noticed is that after 2 years, they start publishing the sub studies.
Right, right.
Not in the New England anymore, but for example, as a cardiologist in the Journal of American College of Cardiology or
Yeah.
Circulation. And
Uh-huh.
you must be very attentive to note that sometimes that is a sub-study and a sub-analysis of the primary trial. Because
Uh-huh.
if you read like, it's not in the title, I think the consort should
Uh-huh.
mention this. It should be
Uh-huh.
in the title that it is a sub-study, a sub-analysis. And these
Uh-huh.
sub-analysis and sub-studies, they become positive very easily.
Yes.
Many of them are post hoc analysis or a priori analysis that suffers from multiplicity because it's a secondary endpoint
Uh-huh.
and subgroup analysis or things like this. It's very. Another thing that I noticed is that it's a post on my blog of the Scott Hart trial that randomized to CT angiography versus functional test patients with suspected coronary artery disease, and the primary endpoint at the clinicaltrials.gov was something like diagnostic resolution,
Uh-huh.
and cardiovascular events were secondary endpoints. And in the
Uh-huh.
New England Journal of Medicine publication, it's written that the primary endpoints, the endpoint of that is a primary, it was the cardiovascular
Uh-huh.
outcomes. You know what I mean? So in
Yeah.
clinical trials, cardiovascular outcomes are one of the multiple secondary. But in the
Uh-huh.
publication in the New England, they say in the abstract the primary endpoint was something like a stroke, MI, and cardiovascular death.
Huh.
So I'll show you this. I think it needs a better because it's a lie in the New
Yeah.
England. What are your take on this?
Well, there is no policing of that. And so that, I mean, you're absolutely right. And we did find that when we looked at clinicaltrials.gov, so that there, there are inconsistencies between what was originally declared and what was published. And
Yeah,
again,
yeah.
uh,
There's no police, and maybe the scientific field need people like you to educate the readers. You know, I believe in educating the readers and the consumers. We are, as physicians, we are consumers of science, and as a consumer, we must be able to analyze the quality of what we are consuming and become more skeptical and educated by this. So it's always a pleasure to talk to you about these issues and learn so much with you. Thank you very
well,
much, Bob.
it's always a pleasure to talk with you. Thank you.
We had so many issues, but I don't want to make this video too long. We're going to do it again soon. So thank you very much.
Thank you.
Bye bye.